This was an interesting prospective phase 2 trial that looked at the utility of single-agent immune checkpoint inhibition for EGFR mutant lung cancers. And the results were consistent with retrospective analyses of the utility of immunotherapy for these patients and subset analyses of prospective trials. The response rate was low. It was 9% in this phase 2 study. However, that was just one patient given the smaller overall N. It turns out that that patient, on subsequent analysis of the tumor ended up not harboring an EGFR mutation on subsequent testing. So this really highlights that there are certain therapies that are much more of a fit for particular patients up front in the first-line setting, and this supports the fact that we should look at giving targeted therapy as a standard of care in the treatment-naive setting for patients with advanced EGFR mutant lung cancers, and not giving a single-agent immune checkpoint inhibitor. We know that EGFR mutant lung cancers, like other driver-positive lung cancers, can express PD-L1, and a certain proportion do have PD-L1 expression of 50% or greater. But even in that situation, I would personally prefer to give targeted therapy rather than considering something like pembrolizumab, while recognizing that the trials that showed the activity of pembrolizumab for 50% or higher excluded patients with EGFR mutant lung cancers.
From retrospective single institution series performed at my own institution, we've seen that EGFR and ALK-positive patients have about a 3% response rate to single-agent checkpoint inhibitor, to more recent meta-analyses that have looked at the randomized studies, generally in the second-line setting, comparing single-agent checkpoint inhibitors versus docetaxel, and specifically among EGFR mutant patients, and really seeing that single-agent checkpoint inhibitor did not result in an improvement in survival compared to docetaxel. In addition to that, we've now gotten some prospective data, and I think the best prospective data with single-agent checkpoint inhibitor comes from the Atlantic study, and this was evaluating durvalumab in specific subgroups, and that included patients with EGFR mutations and ALK rearrangements. Notably, even when that study tried to enrich for responders by focusing on PD-L1 expression, and here it was 25% or greater, the response rate among EGFR patients with that degree of PD-L1 expression was only 12%. And there were no responses observed in the ALK subgroup, despite having high PD-L1 expression. And I think this speaks to a point that PD-L1 expression is a less reliable predictive biomarker in patients with EGFR and ALK-positive disease.